All right, so we're going to talk about blood gases today as far as the arterial and sampling from a central line. Next time we'll talk about capillary punctures, and then on the last end we'll talk about analysis and interpretation of values, which you guys should already be comfortable with, but we'll go back through it. So why do we need to do? We need to evaluate the adequacy of ventilation through the PCO2. That's the parameter that tells us if we're ventilating effectively or hyperventilating or hypoventilating. We'll look at the acid-base status through the pH. We'll look at the oxygenation status through the PaO2, and also with that the carrying capacity as it relates to hemoglobin and these dysfunctional hemoglobins. We'll use it to quantitate response to therapy. So say I put a person on oxygen, did I improve their PaO2? And we'll also look at it as far as determining severity of disease and the progression of the disease as we go along. So as a COPD patient ages, their ability to clear CO2 becomes impaired, and you end up having a PCO2 that rises, and the bicarb rises right along with it to compensate, so we have a normalized pH. Talking about sampling sites. Before that, though, we need to gather some patient data so we know what's going on. So we need to look in various areas as far as the equipment and checking our patient, doing our scene survey, primary survey. We'll talk about some of these other reviews that we'll end up doing, starting with a chart review. So we want to look to the chart to find certainly a physician order, unless there's some kind of a protocol that's calling for a blood gas. This is an invasive procedure and needs a physician's order. Also, there should be some indication as far as why we're doing this. This is not a benign procedure. It is not something that I would just do at a whim. There should be a good indication for why we need this data, and also to see if there's not some non-invasive way that we can get the same information. Find out what the diagnosis is. Do they have any allergies? If we're going to use lidocaine as a pain suppressor, need to find that out. Latex, as far as latex allergies, most of the gloves that we use are not latex based, so it's not as much of an issue. Have they had a recent mastectomy that has not been fully healed? Because as mastectomies affect the lymphatic system, it really more pertains to venous sampling than it does arterial sampling, but usually we will not use the arm on which the mastectomy was done. If they've had a recent arterial line, obviously you don't want to go in the same place and puncture that artery again. You want to give it some time to heal. And then looking at bloodborne pathogens, when I started in the field, we didn't know these things. We didn't know if somebody had HIV or hepatitis. And so the general rule is that we had universal precautions. When I started, we actually did not wear gloves, so that shows you how trusting we were in that point in time. We also want to look for anything that's going to affect the body's ability to clot, because if it is, then we need to hold that site for a prolonged period of time, 7 to 10 minutes, instead of our ordinary 5 minutes. They may have some clotting disorders, like hemophilia. They may have be on anticoagulants for atrial fibrillation, so they may be on Coumadin or warfarin, or even simply routine use of aspirin can prolong bleeding times. You want to look at their platelet count. You want to make sure it's above 150,000, so that that clotting mechanism is intact. And there are obviously clotting times that we can end up, clotting studies that we can end up looking to, things like the partial thromboplastin time. Also, we want to look for specific medications that are clot busters. One of the treatments for somebody who's having a myocardial infarction or an acute stroke is to give them a drug like TPA. TPA stands for tissue plasminogen activator. You don't need to know that. Believe me, you say TPA and people know what you're talking about. But basically it's a clot buster. Its sole job is to break up any clots that are present, which means that I can't form any clots. So if I'm going to do a blood gas on a person with TPA, we seriously got to question, why are we doing this? because the potential for that not to clot and to have bruises and hematomas and other stuff is quite high. Then we want to interview our patient. After we introduce ourselves, wash our hands, confirm their ID, confirm a steady state. Now this means that when I put a patient on oxygen, I can't get a blood gas immediately. I need to allow an equilibration state to, steady state to occur. If it's a ventilator patient, typically we wait about 10 to 15 minutes. If it's somebody who's spontaneously breathing, it's probably closer to 20 minutes to a half hour until they're in a steady state condition where the effects of that oxygen change can actually be evaluated. Might even go a little bit longer with somebody with COPD because we know their gas exchange is impaired. We're going to clarify any necessary information, explain to the patient what we're going to end up doing, and we're going to record various parameters that we need to have so that when we go back and look at the blood gas hindsight, we can say what FiO2 they were on. If we don't have that information, we can't really make any kind of a judgment. So we're going to monitor the heart rate, the respiratory rate, their body temp, what FiO2 or ventilator settings, both invasive and non-invasive. And if they do have any non-invasive monitors or like pulse oximetry placed on them or an end-tidal CO2, we want to be able to go ahead and see how they correlate with our blood gas values. What the heck was that? So what about the equipment we need? Well, we need a needle. Needles are measured in gauges, and the larger the number, the smaller the bore of the needle itself.
The larger the number?
The larger the number. So 14 gauge is like a hose. I'm kidding. Where 25 is very small. Okay. Usually, we use a 20 to 22 gauge for adults, and in most kits that we'll end up finding, Amber was sick today, so she wasn't here to pass out the kits, but we'll get you guys each a kit to practice with, as well as to learn how to put together in a safe fashion. But they come with both a 20 and a 22, so you have both of them available there. If you're going to a pediatric patient, you're going to use a much higher gauge, much smaller needle, because it's a smaller artery that they end up having. We also want to look at the length, and the length goes from about an inch, from a half inch to an inch and a half, and you can see that usually a 1 inch needle is sufficient to reach the radial artery, while the femoral, because it's much deeper, will need a much longer one. And even if you use a long, correct bore or correct gauge needle, you're not going to put the needle all the way into the hub. I mean, it'd be kind of ridiculous as far as the depth that you're needing to go. Some syringe are autofill, which means that we need to preset how much volume of blood we want to draw, and it will fill until that volume is there. Some of them actually have a barrel that moves along with the filling, so you can watch it pulsating in. And some we just need to manually aspirate. Depends upon the conditions that we're dealing with. Most of the ones we'll use our autofill. So we preset the volume that you want to sample, and it goes ahead and fills until that volume is there. We also want to prepare the syringe so that the blood that is collected doesn't clot. So we're going to heparinize that blood either in a couple different ways, or we may have an unheparinized syringe, most common being heparin. Liquid heparin is what we would use if we were just taking a standard off-the-shelf 5 cc syringe. We can heparinize it with our 1,000 units per milliliter heparin. More often than not, the ones we're going to see are what are called dry heparin, or the term is lyophilized. I think it's actually lyophilized, now I'm thinking about it, with a PH, not a T. But that means freeze-dried. So basically the liquid heparin is treated and turned into a little white puffball that you'll end up seeing in the syringe itself. Again, or we can use some liquid. Different types of heparin do make a difference. Sodium heparin is what we typically use for our blood gas. If we're drawing electrolytes, on the other hand, because some blood gas analyzers can actually measure potassium and calcium, we may need a lithium heparin as opposed to a sodium heparin. And then there's some other types of heparin, ammonium heparin, which is used for capillary blood gases. If we're not going to analyze it, if it's going to take some time to analyze, we really need to keep the syringe cool. We'll talk more about that in a little bit. A roll of towel or washcloth, that'll help, and I'm going to show you a picture of that as far as positioning the wrist so the artery is easy to sample from. Vinyl gloves. We don't typically use latex because of latex allergy and the fact that latex gloves are far more expensive. The nice part about the latex is they're skin fit. They feel really tight. The vinyl are kind of and you'll find with blood gases, touch is very, very important. 2x2 gauze pad, alcohol swabs, or something else to be able to cleanse the skin. And although we don't typically see it, some patients still insist on you having a small amount of lidocaine put under the skin to deaden the skin so that when I go ahead and actually do the arterial puncture, it's less painful. I think it's crazy. Why would I want 2 needles instead of 1? It just seems like overkill to me. But and we'll go with that when we get that. We're going to add a needle protection device, and we're going to, if we're using an autofill, we want to set the plunger to the appropriate amount. The Needle Pro is the one that we have. There's a couple other ones on the market. Actually, there's a whole bunch of them on the market. But basically, the idea being is that after I sample the blood, I want to make sure that needle is not something which can inadvertently puncture something else, like you. And we'll show you how to end up using the Needle Pro for that purpose. We can also resheath the needle. You would never do a resheathing of a needle with 2 hands. It's always a one-handed procedure where the sheath is placed on the table and the needle is gone ahead and picked up, scooped up in that process. And I'll talk about the rubber blocks in a second. They're there, right there. Some kits come with these rubber blocks. The problem is that when the idea being is after I draw the blood, I push it into the rubber block, but the tendency is to go all the way through, and now I have exposed needle on the opposite side. There's an example number 1 of one of these other, this is called a peach cap needle protector. There's all kind of designs on the market to be able to protect us from that sharp while I'm doing it. Here's an example of a cricket, and it basically is a little hinged piece of plastic that as I slide my thumb forward, it sheets itself over the needle so I can take it and throw it away. No, not throw it away. Throw it into a sharps container. We rephrase that. This is the one that we're going to use. It's called the Needle Pro, and it's basically a device that has a luer fitting that locks onto the syringe, and then I put my needle onto that, and when I'm done, this just swings down and locks into place in that fashion. So we just have that on the table, and as I click it down, it clicks and seals off the needle so it's protected, and then I can dispose of it into a sharps container. And there's our sharps container. Once I get the needle off, I'm going to go ahead and put a syringe cap on, and then we want to look at removing air from the syringe. This is an example of one of the syringes that as it goes into this cap, there's actually a little space at the end so that as I move the plunger, any air that is there is evacuated out. So all I'm left with is blood in the syringe, and I can take that cap off when I go ahead and do my analysis, and it's a sealed system. So we'll go through how to go ahead and use this protection device, and I'll show you also how to scoop with one hand so that we don't kill ourselves. If we're going to do no, too far. If we're going to go ahead and after we collect it, we want to affix a label to it. Many places have ones that are generated by the computer, so you just plop it on there. But all we should have some pertinent information so we know which patient this was drawn on. I like the art Uriel. Pitiful. Where do we want to draw from? Well, how about if we go back and just review our anatomy? Our best choice is usually the radial. It's far more superficial. It has less other structures near it, like nerves. The second choice would be a brachial. Personally, I hate brachials. And the third choice would be femoral, although there are some other ones that we would end up using or potentially could use, although they're not that common. Sometimes in pediatric patients we'll use some of these other ones, but for the most part we're going to use a radial for our concern. Radial, if you remember, is just above the bend of the wrist, and it's on the thumb side of the arm. And the brachial is located in the brachial fold, or at the elbow. So when we did blood pressure, you were palpating and feeling for the brachial artery. And then the femoral is in the inguinal, just below the inguinal ligament, and it's a much more deep of an artery. We always want to have a good pulse, and we want to look for anything that would prevent us. Things like bleeding, things like bruises, things like swelling. Those are things telling us don't use that site, use an alternative site, especially if I had a recent arterial line there. We look at the hand, a couple of things I want to point out. First of all, the radial artery, again, runs along the thumb side, where the ulnar artery runs along the opposite side, pinky of the finger side. But the beauty of it is that they have a conjunction within the hand, which allows for what we're going to call collateral circulation. Another reason the radial artery is our primary choice, because if something comes and happens, the radial artery becomes damaged, that hand is still being fed by the ulnar artery. So it's kind of a double it's a bonus out there. The other good thing is that the median nerve is located quite a ways away from the radial artery, which is nice because then our risk of nerve damage goes significantly down. So we want to position, this is where that roll of a washcloth or towel or something, it'll actually bring, if I put my arm, instead of in this position, it actually pulls the radial artery more to the surface. Did you find it, Ellie? Mm-hmm. That means you're still alive. Yeah. Brachial, on the other hand, there's my brachial artery, you can see. But look how close it is to the median nerve. So you increase the risk of damage to that nerve, and by extension, then anything that nerve would feel distally could potentially be there. I've been an expert witness on multiple lawsuits, and there's 3 reasons respiratory therapists get sued. One is that they don't recognize a tension pneumothorax while the patient's being mechanically ventilated, and the patient has an untoward outcome. Second reason is there's something wrong with the airway, does not remain stable, and they lose their airway and end up having an anoxic episode. And the third reason is damage to the arm secondary to our arterial blood gas puncture. And again, the presence of a damage does not mean necessarily the negligent performance was present. It just means that a bad outcome happened. If you don't follow the proper protocol, different story. Okay, and that's where we want to make sure that you're doing things correctly. And lastly, the femoral artery is a nice big artery in the leg, but it's really deep. And there's other structures that are adjacent to it, the femoral nerve, the femoral vein. And a way to remember which goes where is to just remember the word Navy. Nerve, artery, vein, Y. Nerve, artery, vein. This is an example of using a superficial temporal artery. Not one that we typically would use, but if a child, that was our best site, that is one that we may end up using. We're going to do, before every single radial puncture we do, we're going to do a test called the modified Allen's test. And what we're looking for is a positive modified Allen's. This means that the palm is going to flush, and it's going to flush in at least 15 seconds. And a collateral circulation, that means collateral circulation is present and a radial artery puncture can be done. If you don't see a flush, or the flush takes longer than 15 seconds, that's poor circulation, and we shouldn't use that site. Okay? Modified Allen's, every blood gas, every time. I'll tell you, on deposition, it's the first question they'll ask you. So how do we do this? Well, we occlude the radial and the ulnar arteries. We have the patient make a tight fist sufficient enough to blanch the hand. So have him make multiple fists. We release the ulnar artery, and the hand should flush within 3 to 5 seconds, and that means you get good collateral circulation. If you got a patient who's comatose, it's kind of hard to hold their hand and do this at the same time. So one idea is just putting a pulse ox on. As I occlude both the arteries, the ulnar and the radial arteries, that pulse ox signal is going to be lost, and I'm going to get an alarm. When I release the ulnar artery, I'll end up seeing that reperfusion happen, and I can verify that I have good collateral circulation. So let me borrow Sean here. I'm going to identify the radial and the ulnar arteries, and I'm going to compress. I'm going to have him make a fist, open up, make a fist, open up. We can see the blanched hand. I'm going to go ahead and release the ulnar artery, and there it becomes pink again. Okay? So why don't you try doing this on your partner that you have there, on each other, so you can get used to doing this. More. There you go. Pressure on both. Okay. And what do I do? Make a fist. Okay. Release the ulnar. See how pink's back up? So that means that we have good collateral circulation. Did anybody fail? Why I'm not surprised.
I've never tried.
You gotta show them.
There was no.
What the run?
My hands are always hot.
I never know that.
Oh, we learned it on our first or our observation.
Oh, they actually did it?
Yeah, they did it. They told us about this, so we knew about this.
When I went, they didn't do it.
Oh, shit, they were asking us. Ours gave
That's
us
so tempting, isn't it?
Why do we clean them out? We're like,
Got it?
ventilated.
Okay, modified Allen's test.
Yeah. So, you know, we're like, oh, shit, put on the test.
And just if you want another picture out of Egan, and it gives you the idea of that how that collateral circulation occurs. Okay, you're performing this modified Allen's test on the right arm of Ms. Gordon, 22-year-old African-American woman. You notice that her fingertips are cold to the touch. After release of the ulnar artery, it takes 12 seconds for the color to return. It's probably not the best site to take, considering either the other arm or brachial. It also sounds like she may have some vascular problems, which is leading to the poor perfusion. And that could be just something as simple as Raynaud syndrome or some other syndrome where the peripheral perfusion is impaired. Okay. One of the things that I want to stress is that at no time will we be doing blood gases on each other. There are programs I know of where they do arterial punctures on each other, and I think it's absolutely insane. It is way too complex of a procedure and too risky. So no, we got our arms for that. I will tell you, when you get to the clinical rotations over the summer, some of the rotations will allow you to begin doing blood gases. Sometimes it won't happen until the fall. Some of them are a little bit hesitant over the summer, but certainly by the time the fall comes around, you'll be able to do punctures. Usually, they try to find a patient that's intubated and comatose as your first patient, so it's a little bit of an ease into the process. Because
I got a question.
Yeah.
With a brachial,
Yeah.
Would we go with a larger gauge?
You might go with a little bit of a larger gauge, yes.
Okay.
And you may need to go slightly deeper than the radial. I hate brachials. When I was starting out, only supervisors or whatever could do a brachial, so I got very good at doing radials. We used to do 15, 20 blood gases a day, and they were all radials, and you got very good at it. So we're going to position the wrist. Again, you can use a roll if needed. Get your gloves on, attach the needle probe or whatever kind of other device that we talked about that we're going to be utilizing. We'll go ahead and attach the needle and loosen the needle cap. Apply alcohol to the site. Wait at least 30 seconds. And again, when you're doing the alcohol, you start from the center of where you're intending to go and move outward. And wait until it's dry. And at 30 seconds probably is how long it's going to end up taking for the alcohol to dry. We also might want to disinfect the gloved fingers that are going to be entering into that zone. If you use a local anesthetic, this is where you would use it, although again it's rarely done. We're going to go ahead and locate that pulse, and then we're going to place our hand with the needle into the patient's hand like this. This is so if the patient moves, I move with them. It's not something where the potential would happen that something could become lacerated inside the wrist. Warn patient of impending puncture and the need to be still. Okay, sir, a little poke. I'm lying. And when we pull the skin taut, you should be able to stabilize the artery. Insert the needle just under the skin. You don't need to go very, very deep. It's pretty superficial. We're going to go at an angle of 30 to 45 degrees. 30 to 45 degrees. Now, it probably doesn't make a difference clinically, but in our mind, the bevel of the needle should be facing the blood flow. So in other words, I'm going to go this way rather than this way. Does it matter? No, the artery's got pressure in it. It's going to fill either way. But you want to really freak people out. Oh, no, you got to go this way. A vein, yeah, I'll agree with you on it, because the venous pressure is very low. Arterial pressure is pretty significant. The bevel should be in upward position, so we're going to slowly advance it to a depth of about 1/4 to 1/2 inch, and we're looking for a flash of blood into the hub of the needle itself. That telling us that we're in the artery itself and we're allowing the blood to fill. If the patient has an untoward effect, a tingling sensation, remove the needle immediately because we may be near a nerve. Again, the pictures I showed are assuming a normal anatomy. There's all kinds of malformations that exist, so you never know anything. If the artery is penetrated completely, mean I went through the artery, just pull it back a little bit until you see that flash. And here's an example of somebody without gloves going ahead and puncturing the artery, and you can see the angle that we're there, 30 to 45 degrees. And the other one is showing up using a butterfly, and I'll talk about that in a second. If no flash is seen, you want to pull the needle back to just below the skin surface and redirect. Now what that means is I'm coming back, not taking it out, but getting as close to the surface as problem and moving it to another position, because I might have missed the artery entirely. Especially with sclerotic arteries, you'll see in older individuals. You're not there to do sewing. Okay. So it's one redirect, and if I'm not getting it, I may be in the wrong spot entirely. They're going fishing. That's about the height of it. If no blood is obtained, remove the needle, hold the site for 5 minutes, and then go ahead and attempt another one. A couple of things that you may end up seeing. If the second attempt is not successful, call another person. If they still can't get it, notify the physician. Sometimes what ends up happening, if you think about it, that needle is a very sharp object, and as it penetrates through the skin, it can actually core out a piece of skin that gets caught in the needle hub. So what you'll end up seeing is you'll see a flash of blood and then nothing. And we call it a tissue clot, and basically there's nothing you can do about it. You just got to attempt again. What we're looking for, this says 2 to 5. 2 is more than enough for most blood gas analyzers. Most blood gas analyzers can actually do it on a whole lot less than that. But at least 2 cc's of blood. Should be pulsating up the syringe, and we should see this nice crimson red color in the process. If flow starts then stops, it may have just been just barely into the artery, and sometimes just advancing a little bit. We'll put it back into the artery cleanly. Once we get the sample, we're going to go remove the air, and we're going to hold the site at the same time. This is where the trick comes in. I draw the blood. I now grab my gauze, put pressure onto the artery, and with this hand, I'm going to do everything else I need to do. One-handed. Gets a little bit tricky, but we'll get you through it. 3 conditions that would make us hold the site longer, more around the time range of 10 minutes, would be, again, the anticoagulant, thrombolytic therapy, or low platelets, or a known bleeding disorder. Any of those ones we were checking in the chart. One condition that would require compression less than 5 minutes, there isn't any. 5 minutes, no peaking. Once we're done, the site should be free from bruising or bleeding or swelling, and you should be able to palpate a pulse. One of my habits that I always got into is after I got done with the blood gas, analyzed it, and got the results back up to the floor, I would go back and recheck that patient again to see what the wrist looked like to make sure there was not any damage there. I don't recommend putting a Band-Aid on it, no. Some people do, and there's Band-Aids in the kit. My personal preference was I always wanted to be able to see that site if there was damage to it. We never want to recap with 2 hands. We're going to use a needle protection device, remove that and put it into a sharps container, remove any air. We'll talk about that in a second. And then we're going to mix the heparin so it's well distributed in the blood by simply rolling the syringe. Label it. If you are going to take longer than 10 to 15 minutes to analyze, first of all, you should be using a glass syringe. Good luck finding a glass syringe. And the second thing you can do is you should be icing it. Okay? The plastic syringes, if it's analyzed within 10 to 15 minutes, will not have a problem. The plastic syringes that we use, actually, if left longer than that, will allow for oxygen in the air to leach in. So you'll get an alteration in your blood gas readings. The only time you would usually have something like that is in the home. So if I was working for a home care company and drawing a blood gas, it was going to take 55 minutes to get to the hospital to drop off in the lab, I would probably use a glass syringe. Ensure the patient's comfort, now that I just stabbed them, and make sure they're, here's my thing here, that the bed rails are returned and all the other stuff. Clean the area. If any spills, again, we're going to use the diluted bleach solution, wash our hands, and then go ahead and analyze. I was fortunate enough in the hospital I worked at that we drew the blood, we analyzed the blood, and we reported the results back. So it was kind of like a closed loop system. Most hospitals now have, the respiratory department has an ABG lab inside but the ICU, so they'll get a quick analysis and quick return of values. Again, document everything. Now the whole system is set up so the computer, you just plug all this information in and it sends it. And again, take a look at the results and see if it makes sense. Do they correlate with the patient? If the patient's nice and pink and I got a blood gas back that says the PO2 is 42, that doesn't correlate really well. And again, we put them in the EMR. And we always want to make sure that, especially if there's values, and we'll talk about this when we get to panic values, if there are values outside of a certain range, it is required that we contact the physician and say, here's these values, these are outside of what we would consider to be acceptable. Okay. Radial, we said 30 to 45 degrees, 60 degrees for brachial, and 90 degrees, so you're going straight down for ephemeral because of the depth involved. Butterfly. This is a butterfly on the upper right corner. It's basically 2 pieces of plastic with a needle behind it and some tubing. And what we want to do, this is where if we need additional blood. So there's many times where I came down to draw blood gas on somebody in the ER, and standing right there beside me was the lab. Well, I can't use lab's venous blood to do a blood gas on, but they can use my arterial blood to do all of their other lab work that they need, CBC, electrolytes, whatever. So what we do is we end up having, with their assistance, we have that butterfly. We use a 3-way stopcock, and we go ahead and puncture the artery, and then as the blood fills, I collect mine, they collect theirs, and everybody's happy. Okay. This may be one where we have a syringe that's just a regular old syringe that's been heparinized that we can go ahead and manually aspirate, or you could use one of the self-filling syringes. So while performing arterial blood gas on Ms. Gordon, you encounter the following difficulties. What do we do about it? Tip of the needle touches the bedside table before putting into the patient. Please get another needle. If it touches your lab coat, if it touches the bedding, don't use that needle. It's contaminated. The artery seems to roll away from the needle each time you approach it. Little rascally butt. Different people have different techniques for how they palpate and pin down the artery. The technique I use is I use a two-finger method. So if this is my artery, I place a finger on either side of it and I kind of manipulate it. Some people will use one finger. There's a whole bunch of different techniques that you'll end up finding. Whatever works for you. I don't care. And you'll get a feel for it. Having difficulty feeling a pulse in the right non-dominant arm. If you can't feel a pulse, you probably shouldn't be doing a blind puncture. That's not indicated. Okay, so look to the other arms or look to a brachial. You observe a blood flash in the hub of the needle and the blood flow stops. Again, if you can't get it by advancing or withdrawing, then you probably have got, like I said, a tissue flash. Patient attempts to jerk her arm away as you're inserting the needle. This is where duct tape works. No, I'm just kidding. That's why you want to position yourself so your hand is on there so they can't move. You've re-angled the needle 3 times and are still unable to get the blood. There's something else wrong. Remove the needle. Don't continue to go fishing, as Stacy said. You notice swelling under the puncture site when you remove the needle. Yikes! That's where we got a hematoma. You got blood leaking out. We want to apply pressure. We probably will apply pressure for longer than a normal five minutes.
What do you do for children? Do you have their parents with them?
For the puncture itself, you can. If anything that makes the child calmer. But again, we try to stay away from as much as possible doing invasive. If there's a way to do it so that we're not having to draw blood, I'm all for it. As you are corking the needle, you puncture your fingertip. Never happens. Oh, wait a minute. Happens occasionally. So we want to squeeze some blood from the puncture site so that it clears it out. Wash the site, alcohol off the site, and then report it. And you'll probably be doing a trip to the ER to get some checked out there. As far as the school is concerned, if you do have an accidental puncture, you also have to let campus police know so they can fill out an incident report on our end. Who do we do a blood gas on? Negative modified Allen's test? Absolutely do not do it. If you got a lesion there, if you got a surgical shunt, say for hemodialysis, a lot of times they'll put it in the wrist. Noticeable infection. And again, never going to do a femoral outside the hospital. I don't know why you wanted, but whatever. And then all those other ones are relative contraindications, meaning you weigh the risk reward that you have there. It's not absolute, but it's relative. Multiple complications that you should be aware of: prolonged bleeding, development of a hematoma. The spasm, the artery itself can spasm, and sometimes when you get a flash and there's no return, that's the cause. Damage to the tissue itself, giving a clot, loss of blood flow, loss of sensation, pain, nerve or vessel damage. And then there's these ones where you end up having a vasovagal reflex, that you end up having fainting, tingling of the fingers, lightheadedness, nausea. And those are all things where you're best off just stopping the procedure and seeing if we can continue later. And again, just some of the things we can end up looking at as far as those kind of procedures. The biggest one there is to try to calm patient and control their breathing. And if we cannot do anything else, that might be an indication for a rapid response call. Some of the errors that can be introduced, and it's really even before we analyze the blood, which we'll talk about in a couple days, but this is one where we end up having an excessive amount of heparin. Heparin itself is very acidic, and it has basically the same oxygen and CO2 as the air does. So if I have too much heparin, I'm going to end up introducing not only acidity to my sample and causing the blood to be much more acidic than it otherwise would be, but I'll also have a CO2 that goes towards 0 and a PO2 that goes towards 150. Same is true with air. Although with if I have an air bubbles, the pH is a little bit different effect. Small air bubbles, multiple small air bubbles are worse than one big air bubble. It's better to just have one big one because the surface area is less. So there's less ability to transfer the oxygen and CO2. What is the CO2 of room air? 0, right? We used it to calibrate the capnometer. We used room air as a 0 point. So the PCO2 of the blood that is actually there will go towards 0. So it'll fall. Falling PCO2 will cause an alkalosis. So my pH will rise. The PO2, on the other hand, is going to go towards 150. What the hell does that mean? Well, it means if my PO2 is 80, it's going to raise. If my PO2 is really 300, it's going to fall. So it's going to go towards 150. Why 150? Because that's the PO2 of air. And if it's got a clot, you definitely do not want to put it in the machine because now you've knocked that machine down until we can remove the clot out of it. Venous blood is another error that you may have. You may have sampled a vein instead of an artery. You'll know it because it's much darker in color. It's much more purple as opposed to this nice bright crimson. You also probably won't have any pulsation. And good thing to do is if they have a pulse ox. If I got a pulse ox of 90, I know from my 40, 50, 60, 70, 80, 90, my PO2 should be 60. And if I measure my PO2 as 38, I'm guessing that's venous blood. Sample too small. Again, the newer machines have gotten much better at handling that. But again, if we get out, like I said, at least 2 cc's, you should be okay. Delay in analysis. This is another complication that may happen. If I leave the blood gas syringe sitting on the counter, go get lunch and come back, remember that blood has living substances in it called leukocytes. Those leukocytes will consume oxygen and create CO2 through the metabolic process. So what will end up happening is my PCO2 will rise and my PO2 will fall. And obviously another analytical error, pre-analytical error, is I label it wrong. So the wrong patient gets the results. Not a good thing. Some other errors, you getting punctured, ouch. And we know about all the stuff we need to do there. And not mixing it well, plasma and the actual blood contents are different, so you'll end up getting a little bit of a error from that. And again, it just raises the incidence of clotting. We talked briefly about some central lines or some other lines that may be in place. Arterial sampling is available from putting an arterial line in, but also is monitoring of blood pressure on a continuous basis. So those are 2 bonuses. And really it's more than just you can draw any blood off an arterial line. You can even use, again, for venous, what we would normally think of as venous sampling. Radial, probably the most common site for a arterial line placement, but there are some other stuff. And when Lori goes through 2050 next fall, she'll end up talking about arterial line placement. Although in Michigan, it's a rare occasion where we start arterial lines, I guarantee you go anywhere else in the country, and RTs are starting arterial lines. It's part of their normal practice. And not only is the catheter here placed into what looks like the brachial, There's a transducer there to measure blood pressure, and there's a 3-way stopcock that we're going to use to sample blood. More on that later. I'm not going to test you on that kind of idea. PA catheter. Remember back module G from 1050, that horrid hemodynamic module made you cry? We talked about floating a catheter through a large vein into the superior inferior vena cava, and then into the right atrium through the right ventricle and into the pulmonary artery. Measure pulmonary artery pressure. We can also draw blood off that distal tip. That blood is considered mixed venous. What mixed venous means is that if I draw blood from the antecubital vein in my elbow, it's telling me the metabolic status of my hand. If I draw it from a femoral vein, it's telling me the metabolic status of the feet. I want to know the overall. Tell me, include the kidneys, the brain, everything together. The only place blood has been allowed to mix that sufficiently is in the pulmonary artery. So if I can do a distal sample, I can end up getting true mixed venous blood. And a central line will also allow us to sample off the CVP catheter. It's a poor man's mixed venous. It's not really mixed venous, but it's something at least. It hasn't been there long enough to mix. So we're going to use the simulated arterial puncture on our arms that we have back here. I encourage you to try both right and left-handed. Become proficient both ways, because you may be in a situation where I have to do it one way or the other. Okay? And we can actually lay the arm into bed so you can get a practice there. This is the Grand Canyon. This is an actual structure that is there. I don't know that I would walk on that either. I went to the CN Tower in Toronto, and they have a glass floor over there where you can walk out and you can look. No, thank you. Nope, nope, nope. But anyway, questions on arterial puncture?
Enough erosion.
Question